Morning, friends. So today I'll be just giving a brief overview on this echo assessment of aortic stenosis. I'm sure many of my friends would have listened to the video on aortic stenosis overview and what an intensivist should know that I did around a week back. So as a continuum of that, I'm just doing this echo assessment mainly from the intensivist standpoint. What are the key things that we look at when we are assessing aortic stenosis with an echocardiogram? So wish to acknowledge my colleague, Dr. Pradeep Surli, who helped me develop this concept. But as I said, now most of the videos I'll try to incorporate MCQ questions. So this time I have around 6 trainees sitting with me. So I'll be asking them the question. And I'll let you know what they've answered, and we'll make it more interesting. So I have a few MCQs pertaining to the talk I'm giving. So it's not outside the domain of this particular talk. Okay, so we'll just look into what are the key aspects that an intensivist should know while assessing aortic stenosis in echocardiogram. So just keep this picture in mind. So I'm sure when you saw the last video, I did show you how we look at it from echocardiogram. So once doing echo, just be aware there is something called LVOT. So this is the left ventricle and there is a left ventricular outflow tract. And the key aspect when we are assessing aortic stenosis in echocardiogram is our understanding of the flow and velocity through this LVOT. See, if you see this picture, when the blood flows through the LVOT, because here the velocity may not be very high because the opening is broad. And then the opening tends to get narrowed and then the velocity increases. So there are two velocities that we look at. One is at the LVOT area. We measure the velocity, which is called LVOT velocity time integral. Then we take an area where the velocity peaks, because as the opening becomes narrow, you would understand that the velocity tends to increase. So this EOA is effective orifice area. GOA is geometric orifice area. So just remember EOA, effective orifice area. So we look at the pressure difference between the LVOT and the effective orifice area as the delta pressure. So there is a pressure difference because obviously this pressure is calculated by using the velocity by Bernoulli's principle, which I'll talk about. So we look at this gradient as a measure of the intensity of stenosis. Just keep this as a physiological understanding that there is difference in the velocity when the blood is ejected out of the ventricle at LVOT area and at the effective orifice area, which is narrow and the velocity is much higher. So the assessment of aortic stenosis is for intensivists, at least, because the cardiologist may use little more advanced domains. For intensivists or for anyone for that matter, there are three variables we look at. One, we look at aortic valve area. So which I did show you in the last video. We look at whether it is, we call it if it is severe, if it is less than 1 centimeter squared, and if very critical, if it is less than 0.5 centimeter squared. And then we look at the peak transvalvular velocity. So we look at the velocity of blood that is ejected out of the LV as a peak velocity, and which we look at as peak transvalvular velocity. And of course, the third one, which we always look at, is peak transvalvular gradient or mean pressure gradient, what I used to call. So if it is more than 40 millimeter mercury, we call it as severe stenosis. And if the peak transvalvular velocity is more than 4 meters squared, then we call it as a severe ES. So these are some of the key variables that we look at when we are doing echocardiogram. So as I showed you in the previous picture, so here is the LVOT area. So we look at the LVOT area here, then we look at the velocity time integral at the LVOT, then we look at the velocity time integral at the aortic valve area. So aortic valve area is calculated by this formula. So we look at the LVOT cross-sectional area multiplied by LVOT velocity time integral. So we look at the velocity that is happening at the LVOT, and then we look at the gradient by looking at the velocity time integral or the velocity at the aorta, which is much higher. So we look at that as a pressure gradient to calculate aortic valve area. So when you look at the LVOT, we take the measurement just distal to the valve area, and that if you see in this picture, it is around 19 millimeter. So LVOT area is calculated by pi multiplied by LVOT diameter divided by 2 to the square. So this is the formula that we use to calculate LVOT area. So the LVOT, so as you see, AVA cross-sectional area is LVOT area. So cross-sectional area into LVOT BTI divided by LVOT of the aorta. So when you look at the LVOT areas, obviously you need to take a diameter which is distal to the aortic valve. And then once you take this diameter, you get this. So you have to do the pi into LVOT diameter divided by 2 into 2, that gives to LVOT area. And to calculate LVOT VTI, which I'm sure many intensivists would know, so you place the cursor in between the edges of the septal endocardium and the anterior mitral leaflet during systole. So you have to place exactly between the edge of the septal endocardium and the anterior mitral leaflet and put a pulse wave Doppler. Put a sample there and put a pulse wave, you get LVOT, and you have to take a trace of this, which will give you LVOT VTI. So you calculate LVOT area multiplied by LVOT VTI divided by aortic VTI. That gives you aortic valve CSA, cross-sectional area. So, and for calculating the aorta VTI, so this is important. So you have to place the cursor at the aorta. So this has to be into the aorta. Then you use continuous wave Doppler. So you have to use pulse wave Doppler for LVOT VTI. So the question I may ask is, why continuous wave Doppler for aorta? Because for any high flow velocities, so one has to use continuous wave Doppler. So for aorta, you have to put continuous wave Doppler, which will give you aortic valve VTI. So you got LVOT VTI, you got aortic valve VTI, then LVOT surface area you calculated by taking the diameter and multiplying into pi into diameter divided by 2 squared. So that is the formula used. So this is the way you take the aortic VTI and then you get the cross-sectional area of the aortic valve. So if you see, so this is just a pictorial representation where again you have placed the cursor at the LVOT, so and at the aorta, and you placed a continuous wave Doppler. So here you get aortic valve VTI. So you have placed the cursor into the aorta, and then you have to place a continuous wave Doppler, which will give you aortic valve VTI. So that's about the aortic valve. So I said there are three parameters that we measure. One is the aortic valve cross-sectional area, which you saw. The second one is you look at the peak velocity. Then third one is you look at the mean pressure gradient. So how about measuring peak transvalvular velocity? I think this I showed you in the last video also. So you have to understand this conceptually, that the LV pressure increases and it has to equal to the aortic pressure for the aortic valve to open and for the blood to be ejected. So which means there is no pressure gradient. In aortic stenosis, the LV pressure has to supranormally increase and to eject the blood out of the LV into the ventricle. So which means the LV pressure is more than the aortic pressure, and that leads to transvalvular gradient, which is aortic pressure with LV pressure. So this we spoke when I spoke about aortic stenosis. That's why there's a pressure gradient that gets built up. So this pressure gradient, which we talk, now you relate to this, because this pressure gradient becomes more accentuated because the velocity of the blood significantly increases from the LVOT to the effective orifice area. And this pressure gradient is calculated by applying Bernoulli's principle, where Bernoulli's principle equates pressure gradients is captured in relation to the velocity by multiplying 4 into V squared. So V squared is the velocity. So this is the sort of a equalization or representation of the pressure gradient by calculating the velocity across the gradient. So Bernoulli's equation calculates the pressure gradient by 4 into peak velocity squared. So that is the equation that it uses to calculate the velocity, which echo machine does for you. And the mean pressure gradient is calculated by averaging the instantaneous gradient. So that gives you the mean pressure gradient. So if you have to calculate the peak transvalvular velocity, so as I said, for velocities, you have to place continuous wave Doppler. So you place the cursor at the LVOT, then you have to place continuous wave Doppler. You get a graph like this, and you have to trace this graph to get the peak velocity. So if you see in this, there is a mild obstruction. So the peak velocity is 2.6 meter per second. If you recall, I'll show you the table again. If it is more than 4 meter per second, it means it is severe AS. If it is 3 to 4 meter per second, it's moderate AS. If it is 2 to 3, it is mild AS. So here, if you can call it as a mild obstruction because the velocity is 2.6 meter per second. That you get it when you trace this Doppler curve, and then the echo machine would give you this reading. So I'll just show you how we did it. So when there is, so if you see this, there is 3.6. So this is a moderate obstruction. So when you need to ascertain there is subaortic obstruction, so there is a concavity in the curve above. Usually this has to be convex. So if there is concavity, it will tell you there is subaortic obstruction. And this is a moderate aortic stenosis because your peak flow or peak flow velocity is 3.6. So 3 to 4 is moderate, 2 to 3 is mild, and more than 4 is severe aortic stenosis. And so in subaortic obstruction, there is late peaking of this velocity that tends to happen. So I'll just show you this image. Just have a look as to how you do it practically. So you see there is a aortic flow here, the blue one, which is going into the LVOT. So you place the graph, you place the cursor there and you get a trace like this that will give you both peak velocities. So here you see velocity is 4.13 and mean pressure gradient is 39, which is almost edging towards severe aortic stenosis in this. So again, I'll just show you the video again. So this is our patient where we did. So you can see here. So this is a patient with severe aortic stenosis. He said LVOT is open. So you have an aortic inflow here. Then you place a cursor and then you take a continuous wave Doppler. So this is a continuous wave Doppler. And if you see here, aortic valve pressure gradient is 49, which is severe aortic stenosis. And then the echo machine auto-populates the velocity itself. So here, if you see, aortic valve peak velocity is 431 centimeters, which is 4 meter per second. So which is severe aortic stenosis. So this is our own patient where we did the echocardiogram. So if you see here, as I said, there will be convexity here. There is no concavity. If there is concavity, we call it as a subaortic obstruction. So this is the RV. Let's go on to RV. You can see here, there is more of convexity. If there is concavity, it just shows you there is subaortic obstruction. So just to recap, so criteria for aortic stenosis with normal, which I think I covered in the last video also, it is called mild if valve area is more than 1.5 centimeters squared, mean pressure gradient is less than 20, and velocity per second is 2.6 to 2.9, we call it as mild. And indexed valve area is aortic valve area divided by body surface area, and it is mild if it is more than 0.85. Moderate, valve area is 1 to 1.5, mean pressure gradient is 20 to 40, velocity is 3 to 4, and indexed valve area is 0.6 to 0.85. So indexed valve area is aortic valve area divided by body surface area. Severe, you call it when valve area is less than 1, and valve area, you know how to calculate now. So you have to take LVOT cross-sectional area into LVOT VTI divided by aortic VTI. And mean pressure gradient, you put the cursor at the LVOT and put a continuous wave Doppler that gives you velocity and mean pressure gradient. And mean pressure gradient will be for more than 40 in severe, and velocity will be more than 4, and index valve area will be less than 0.6. And it is called critical aortic stenosis if it's less than 0.5. So that's about the echo assessment. So the three things that you assess, one is aortic valve cross-sectional area, which you see the areas mentioned here. If it is less than 1, it is severe. 1 to 1.5 is moderate. More than 1.5 is mild. And the second thing is you look at the peak velocities. Velocities more than 4 is severe, 3 to 4 is moderate, and less than 3 is mild. And then you look at the mean pressure gradient. So these are the only three variables one has to at least keep in mind while assessing the severity of aortic stenosis. So now for all our trainees, I'll go to the MCQ. So I'll ask all my trainees who are sitting here after this talk whether we have a good clarity on aortic stenosis. So maybe my first question will go to my colleague, Dr. Benjamin, who is sitting here. So which echocardiographic parameter is most commonly used to assess the severity of aortic stenosis? Is it LV ejection fraction, transvalvular pressure gradient, aortic valve, annulus diameter, left atrial size. Benjamin, loudly.
Option B.
Okay, he's given a right answer. So the B, transvalvular pressure gradient is the right answer. So very good. So my trainees are paying good attention. So the answer is, because we did speak, is the pressure gradient which really determines the severity of aortic stenosis. Although left atrial size increases, but it happens much later stage. And we don't look at aortic valve annulus. We look at the aortic valve cross-sectional area. LV ejection fraction is representation of advanced aortic stenosis. Generally, they are overestimated. If it is low, it tells you that the LV is completely decompensated, which I covered in the last talk. So we'll go to the second interesting MCQ, which my good friend Dr. Shastri will answer. Sanjay Shastri here. So which echocardiography of parameter is most commonly, oh sorry, that's, yeah, which, okay, so this is the one. So what is the normal range for aortic valve area in a healthy adult? So which I said, severe is, we said it is less than 1. So in healthy adult, what is considered normal valve area? Sanjay Shastri. Sorry? Okay, he gives an answer of C, I think, which is correct, 2.5 to 4 centimeters. Fantastic. So my trainees are good, so they're answering all the questions correctly. So 2.5 to 4 is normal. So greater than 4 is unlikely. So C is the correct answer. So if it is less than 1, it is severe. 1 to 1.5 is moderate. Less than 0.5 is critical. Okay, now the question goes to my other trainee, Dr. Megha, who is a DRNB training. So severe aortic stenosis. I don't know what is the severe aortic stenosis is. I think there is this. By aortic valve area of less than, oh sorry, I've already given an answer. So it is 1 centimeter. So I'll skip this question. So sorry. So severe, we call it as severe aortic stenosis. As I said, if it is less than 1, if it is 1 to 2, it is moderate, and more than 2 is normal. So 1 is less than 1 is severe. So less than 0.5 is critical. I'll skip this question. So which Doppler you calculate the pressure gradient across the, which Doppler principle we adopt to calculate the pressure gradient across the aortic valve? Is it Bernoulli's equation, Poiseuille's law, Starling's law, or Doppler shift equation? Okay, very good. So A is the correct answer. So my trainee Megha has given a correct answer. Bernoulli's equation is the right answer. Okay. So what is the sorry friends, I think this one is covering. Okay, maybe I'll ask Yashaswini, this my other trainee. What is the primary echocardiographic findings in low flow, low gradient aortic stenosis? Is it normal LV function, reduced transvalvular pressure gradient despite severe AS, increased cardiac output, or elevated left atrial pressure? I think you sorry, I think I've shifted this. So the answer is answer B. So it is just move this. So the answer is reduced transvalvular pressure gradient despite severe aortic stenosis. Sorry, there's some obstruction there. Okay. So what calculations would we use for Doppler velocities to determine the severity of aortic stenosis? So question goes to Dr. Pratibha. So is it left ventricular ejection fraction, or is it aortic valve area using the continuity equation, or is it the ejection fraction of the aorta or left ventricular mass index? So what calculation we use as a Doppler velocity to determine the severity of aortic stenosis? Okay, great. So Pratibha gives the answer B. So that's correct. Aortic valve area using the continuity equation is the right answer. So then we go to the last question. So which echo? So this is a general question to all of my trainees here. Which echocardiographic finding is characteristic of paradoxical interventricular septal motion in aortic stenosis? Is it normal motion of the interventricular septum, or hyperdynamic motion of the septum during diastole, diminished motion during systole, or systolic anterior motion of the septum? Come on, guys. So think of aortic stenosis. What happens to the interventricular septal motion in severe aortic stenosis? So I think my trainees are giving wrong answers. Hyperdynamic. There will be diminished motion during systole because of the mitral valve, which is because there is LVOT obstruction, there is limitation to the mitral valve movement. So there's a diminished movement, which is called as paradoxical interventional septal motion is a hallmark of aortic. So please remember all trainees, if this question asked, there will be a paradoxical interventricular septal movement because of limitation of its movement, because of the LVOT obstruction and the opening of the mitral valve, which gets impeded. So that's about it, friends. So hope it was useful. So request all of you to submit your valuable work to a Journal of Acute Care, and you can visit my website to rehear to this lecture. So thank you. Thank you, one and all.